Go ahead and get started. Okay, good afternoon, everybody. We're going to go ahead and get started. My name is Adesuwa Akhetuamhen. I am a research fellow at UCSF in the National Collection Scholars Program.
My name is Abiye Ibiebele. I'm currently an emergency medicine attending, working in the Trinity Health System in Southeast Michigan.
And I'm John Bailitz. I'm currently Vice Chair of Academics at Northwestern.
And today we're going to talk to you about how to design, implement, and evaluate a cultural competency curriculum to address healthcare disparities. Before we begin, I would like to acknowledge ADEM for sponsoring this talk, and I would also like to acknowledge the authors of this article that was published in Academic Emergency Medicine, titled Diversity in Emergency Medicine Education Expanding the Horizon. In it, they discuss how to really improve cultural competency education and really lay the foundation for the work that we are going to present today. So we have no disclosures. In general, we're going to talk about cultural competency and walk you through a framework using Kern's model for how to develop your own curriculum. We'll go through each step and really highlight the different strategies that we used to be successful in accomplishing our goal. So what is cultural competency? It is the ability to effectively use cultural knowledge and skills in cross-cultural encounters. It is truly a learned skill that helps us to just understand cultural differences and facilitate communication between populations, making sure that when I'm speaking to a patient, they hear what I'm saying, and then when a patient is speaking to me, I hear and understand what they say to me as well. And I think now it's really important to emphasize that cultural competency is not just memorizing stereotypical facts about a patient's background and calling yourself an expert in their culture. In fact, the original definition of cultural competency emphasizes this by saying that it's an ongoing, lifelong process, developmental process that requires consistent growth. And nowadays, you will hear terms like cultural humility and cultural awareness to better reflect this fact. So, why is cultural competency important? Well, in 2002, the Institute of Medicine wrote a report, and in it, they state that ineffective communication in the medical encounter may lead to patient dissatisfaction, non-adherence, poor health outcomes, and subsequently, racial and ethnic disparities. And in it, they recommend that cross-cultural education should be integrated into the training of all current and future health professionals.
And so now, 20 years later, the ACGME finally in the core program requirements list cultural humility as one of the core program requirements and includes these skills as well. Competence in communicating effectively with patients and families, competence in respect and responsiveness to our diverse populations that we see every day in the emergency department, and responsiveness to the larger context in the social determinants of health. So now in 2017, when Ade and Abiye first approached me and said, hey, we want to really teach everybody all about cultural competency, we all said, great, what a great idea. But it can't just be another one and done lecture. So instead, we pulled out Kern's model of effective curriculum design in medical education, and we worked the process of curriculum design. So we started in the fall of 2017, and we didn't really begin implementing our curriculum until 2018.
So when we began to brainstorm how we were going to implement our curriculum and how we were going to develop it, first we wanted to look at the literature to see what the need is already. And one study that stuck out to us was in 2017, a survey went out to all ACGME accredited EM residencies, and in that they asked them just, do you guys have a cultural competency curriculum? Do you guys have any way of measuring, or is there any interest in a universal curriculum? And of this, 68% of those that responded said that they had a cultural competency course, but only 1 out of 5 of them had any way of measuring residents' comfort with cultural competency. And 93 expressed an interest in a universal shared curriculum. So we knew that there was a need out there, but we were at Northwestern, and we wanted to figure out how we can make a curriculum that best served our needs at Northwestern. And one topic that had been discussed in the literature is using the TACCT survey. The TACCT stands for Tool for Assessing Cultural Competency Training. It was developed by the AAMC, and initially it was for medical schools for undergraduate medical education. It was developed by leaders in survey development, by leaders in medicine, as well as anthropology leaders as well, to kind of fully encompass all aspects of cultural competency. The survey has 42 objectives spanning 6 domains, which you can see listed there. And it had been used in other aspects of medical education, from nursing to dental education to rehabilitation programs. So we wanted to adapt the survey for specifically emergency medicine residencies. So what we did was we took the 42 objectives and we made a survey out of it after we adapted it to EM-specific objectives, and we administered it to all of our residency and core faculty. And what we did was we just had people, the way the survey is developed, it's a yes-no survey. So with each objective, we asked our participants if the objective stood in the curriculum as it currently stood. So if it was present, based looking at didactics as well as on-shift learning and teaching. Of the 42 objectives, what we did was we took the bottom quartile of the responses, and we made that the goal and the target for our curriculum. So you can see the objectives listed up on the screen there. They span 4 domains of the original 6. So once we had all of these objectives, we were brainstorming how do we best teach this and how do we best incorporate this into our curriculum. So we talked to our program director, we talked to our chief residents, we talked to our ED social workers, as well as institutional leaders in health equity and advocacy. Looking at educational strategies, one source for us was these 2 books, the first and second edition of Diversity and Inclusion and Quality Patient Care. This was made by emergency medicine physicians and has case-based vignettes of different scenarios that would come across on shift. And we use this topics from this book to kind of springboard our discussions. We had case-based discussions based on topics in the book and then expanding it to experiences that our participants had on shift. In addition, we also did didactic lectures as well.
Now, as Abiye mentioned, implementation was a bit easier since I was the program director, but we also had the assistant program director on our curriculum planning committee who is in charge of planning our weekly didactics. So Naz helped join that committee, give a voice to that committee, and then helped work in those 11 objectives ultimately into 8 different engaging sessions spread over our 2-year recurring curriculum.
So I'm going to take the next 2 slides to really talk about the 8 sessions that we used to meet the goals of our objectives and go just over the curriculum outline. So for the first session, we brought the emergency department social workers, Meredith and Allison, to really explain to us how they provide care for vulnerable patients. And what they did was they chose different cases from that diversity and inclusion and quality patient care textbook that Abiye mentioned a few slides ago, and they just had frank discussions about how they care for those patients, which was really helpful for the participants to hear. In session 2, we brought Dr. Michelle Byrne, who was a family medicine resident at the time, and she talked to us about the idea of race being a social construct and gave some practical advice about how to identify implicit bias both in ourselves and in others. For session 3, we had Dr. Christine Schaefer, who is the director of the Transitional Care Clinic, and Megan McVeigh, who is the social worker of that clinic, who spoke to us about how they provide care for patients who otherwise don't have primary care services. So a lot of times when patients are discharged from the emergency department and need follow-up, like this is a special clinic that they can go to if they don't have a primary care doctor who can better support that transition to family medicine care. And so it was a really great opportunity to see a real-life example of how you can help partner with communities to address their needs. The 4th session was run by Dr. Robert Torelli, who's actually an attending at Northwestern, an emergency medicine attending at Northwestern, and he was able to give us real-life examples of how he's been able to integrate programs within the emergency department to really support the large percentage of patients who are experiencing homelessness and who have HIV that we see in Chicago. In session 5, we invited again Allison and Nadia, another one of our emergency medicine social workers, to run through cases from diversity and inclusion and patient care. And then in session 6, Abiye and I had the opportunity to talk about the history of racism in medicine, and really outline how our emergency medicine organizations emphasize diversity, equity, inclusion, which was one of the objectives from the result of the needs survey. In session 6, we had Dr. Adesuwa Akhetuamhen, who's an OB-GYN attending. She runs a special clinic for victims of human trafficking. Chicago's a major city with 2 large airports, and we actually have a very significant number of these patients. And so she was able to provide a trauma-informed model of how we can identify and care for these patients in the emergency department and then subsequently get them connected to her clinic when they're discharged. And then in our final session, we invited Dr. Garth Walker, who was then the Health Equity and Economics Research Fellow at Northwestern, and who's now the Medical Director for Value-Based Care at Rush. And he was able to give us a talk about the social determinants of health and specifically how that affects the African-American population in Chicago and give real-life examples of how he partners with that community to better address their needs. So after we implemented the course, we then completed the final step, which was evaluation and feedback. And we used a unique retrospective pre-test, post-test survey where we were able to put together attitudes, preparedness, and behavior questions and map them based on our learning objectives. And we were able to then generate both just general feedback, which you can see on the quotes on the side there. My favorite is the one at the bottom, which states that there's lots to know, lots I don't know, but we're determined to keep working to be better. And then in addition, we were able to obtain quantitative data using frequencies and one-way ANOVA statistics.
So focusing on some results from our feedback survey was looking at respondents that said, respondents in terms of what they were saying. So one is that 81% said that cultural competency was very important to their practice. Also majority said that they were, after our class, that they were sometimes or always practicing strategies to reduce bias in others, and that more than half said that they are very, very comfortable interacting with and treating patients from a different background. We did compare all of these results to what the pre-test, and these were all significant changes from before the curriculum. Some things that we need to keep working on was, a little less than a quarter said that they felt very prepared to identify community leaders to address healthcare disparities, and less than 50% said that they were very prepared to collaborate with communities to address healthcare disparities. Kind of reflecting on this, because our curriculum was based on didactics and based on case-based discussions, these 2 specific goals and objectives, that you kind of have to have the in-field experience to work on them. But then even looking at our pre-test, the 17% was an increase from 5%, and the 23% was an increase from 11%. So there was improvement, but it's definitely something to keep working on.
So in conclusion, we hope that this talk was helpful for you in terms of designing, implementing, and evaluating a cultural competency curriculum. We know we went through a lot, but again, the purpose of this talk is just to kind of lay the foundation and hopefully give you some tips on how to get started. I do want to highlight that we were able to publish an article in Academic Emergency Medicine. Here's the QR code that you can scan just to get more information. And in general, I would say one major takeaway that I hope you can take away with you is to don't feel like you have to reinvent the wheel. We really benefited from the diversity and inclusion in quality patient care textbooks. And I would say if you're looking for a place to start there. I have a copy in my backpack if anybody wants to look at it. But I think that you just got to kind of take the first step, and we hope that this will be helpful for you.
I'd say for me, a major takeaway is just going through the process of initial brainstorming to going through the implementation, and then overall, assessing the curriculum afterwards. And just that whole process definitely made, hopefully, something that is long-lasting, and also for me is going to lead to effects in my career as well.
Yeah, for myself as an educator, I think I had 2 big takeaways. One was just the pure joy of being an educator and working on a shared passion project with your learners and just going to the next level and working to improve your program. And then, the second takeaway was just how powerful Kern's 6 steps can be. And as I think I told a day in 2017, every step of Kern's designing effective curriculum can be a research project, can be a poster, can ultimately result in behavior change at your institution and result in a publication of an article that was actually, we're proud to announce, Ade's article was recognized as one of the leading articles by AWEM at this meeting as well. So congratulations to Ade on that.
Yep. So now we're open to questions if anybody has any. Sure, yes. We'll start with you in the back, yeah.
Thank you so much. This was a great presentation. I'm wondering what you guys think about. I feel like there's more of a shift and move towards talking about structural competency more, and kind of moving away from like mastering race, ethnicity, and culture, but like mastering the social structural determinants of health when we talk about these things. So I'm just wondering what your guys' thoughts on that. I'm sure there's lots of overlap, and if there's any curriculum development around that as well.
I agree with you. I think that when you try to address discrimination and kind of racial disparities specifically, there is a framework that talks about needing to address it on the kind of internal, interpersonal, and structural level. And that framework really emphasizes that like the structural level is really the piece that needs to be addressed in order to like make progress. But I would also say that you can't ignore the other two levels as well. So I think what would be helpful for this is just keeping that Kern's model framework, but then still being able to apply it to cultural competency, structural competency, kind of making sure you can address all those levels. But being able to use this framework, I think, can be helpful in addressing that. But I agree with you. You have to address it at the structural and the other levels in order to make meaningful change.
It's interesting what this project has led to as well. I think right after Ade and Abiye started their efforts, then it was the Social EM Academy Forum. And then this year, this curriculum has been continued by some of our residents as a social justice curriculum. And so I think there is a natural evolution here, but there are certain foundational pieces that we need to bring to the bedside too.
You had your hand raised in the back.
Yeah, I was wondering about the opportunity to do this similar curriculum, but more collaboratively or interdisciplinary. Like I know you incorporated social work, but we've done a lot of focus on resident education and our provider education, but it sometimes clashes with our nursing. And I wish we were more on the same page and increasing opportunities for us to learn side by side so that we can work better together to care for our patients.
I think that is a really important point because there's only so much that I can do as one member of the team that's caring for this patient, and so it absolutely has to be a group effort. And when Abiye and I first began this work, we did reach out to our nursing leadership who expressed interest and support for this. And so I think it's one of those things where ideally we'd be able to all learn together, but even if it's just sharing resources with multiple members of our team, emergency, clinicians, nurses, pharmacists, ED social workers, everyone who will interact with that patient and have an impact on their health outcome, I think should be included. And I agree with you. We definitely need to make sure that it's interdisciplinary. Yes?
Any thoughts about how to kind of bring this kind of cultural competency program, let's say into residency program that is a little bit resistant, let's say, or things like 2 lectures a year about cultural competency is enough, for example?
Yeah, I think it's a good question. Good question. I think part of it I think a lot of it has to do with like what the institutional buy-in is. I do think that some sort of needs assessment, whether it's a TACCT survey or something else, is helpful in terms of letting people in charge and in both in like education as well as departmental leadership aware of like what is not currently being addressed. I think in addition, if there is any sort of ability to kind of look at what your patient population is and like what their experience has been as well. I think that's another way to kind of get more buy-in, but it is a hard, that is a hard kind of a hurdle to kind of get over.
Yeah, I think one thing that really helped us was really pulling out those requirements from ACGME. And for the first time this year, like cultural humility is actually like listed as a requirement. And so I think having that in your pocket is a good way to sell it. And then just emphasizing what Abiye mentioned, when you come to them and you say, hey, we have these 42 objectives, we got a lot of pushback, like this is too much, there's no time. But then being able to say, we don't need 30 lectures. We just have kind of 11 things that we're going to focus on. Maybe you can give us 8. And this is what everyone has expressed an interest in wanting to learn more about. I think it was helpful to get buy-in, but it definitely took some time. But those were the 2 biggest things that really helped us kind of get the ball rolling. Yes?
Wondering if you have ideas how we can add more cultural humility when we build cases for medical learners. So for example, we have a 72-year-old woman with hypertension, and someone started to create a picture of what this patient looks like. So is that in her head, is that a white woman who's heterosexual, who is from a middle class? So do you think there are strategies or ways that we could build more of these concepts into the way we utilize cases in education, in everyday practice?
Absolutely, and I think there's a lot of work that's being done in that space because it definitely shouldn't matter, like some of those kind of elements that you described, I think can definitely bias us in terms of like what we think about this patient who comes in with, which should just be like a simple chest pain complaint. So I would say that there's definitely a lot of work in this area. I think one area that's really kind of gotten a lot of traction is just kind of looking at medical records and seeing how people describe the patients that they see, and being able to use that as a way to measure, like, okay, maybe you're emphasizing these kind of other social factors a little bit too much in your medical record, and being able to provide that feedback to the provider, I think is helpful and is a way to kind of measure what you were getting at.
I was just curious how you built in faculty support and buy-in of the learnings, because I think this is a great program, and I know that on the floor there's not this, I see the nodding, so I'm just going to be quiet.
Yes, is the answer to that. I think it's always a challenge to have faculty attend resident lectures, and particularly lectures like this that might not occur on the M&M or the trauma conference day. And so you're absolutely right. That continues to be a challenge that we're exploring. And it's interesting, there's generational differences too. Like I think getting to an earlier question, like we have to give this to our learners. This is their generation. This is what they identify. The world is getting better, thank goodness, because of them. But older, more stubborn generations, you have to find different strategies, bringing it to faculty meetings, bringing it to things like nursing huddles. We can't get our nurses to attend their residency lectures. There's 200 of them, but we can deliver it in a way that makes sense for them. So, absolutely right, big challenge.
Impact of this time in practice and moving forward from. I remember in our intern year, you guys were presenting this, and now you're saying what you've done.
Yeah, I think for me, it's, when I work with, residents and learners, and even if I'm not doing like a formal didactic or formal educational session, just, discussing some topics that come up on shift. I think that's the most natural way that it comes up, is seeing a patient and talking about, okay, like they came in with this, like have we considered, if you want them to follow up, have we considered, like, do they have help with following up? Is there any ways that we can help them here in the ER? They may not have that much connection to care. So I think that's how it's just kind of enhance my ability to communicate with people on shift, and also, hopefully help to work for our patients on shift.
Yeah, I would say for me, this has really had a big impact on kind of the trajectory of my career. I've really seen it as an opportunity, not just to address how we teach about cultural competency and health disparities, but also then take it to the next level and actually focusing on kind of like the structural issues that we see. And it kind of gets back to an earlier question. It's what kind of motivated me to then go more down the research path and take 2 years to do this research fellowship to really develop those skills to be able to measure these inequities on a structural level, and then combine the education with the ability to make impact, like in real time when you're seeing a patient in front of you, and kind of put those policies and structures in place to have a meaningful impact. So that's what I hope to be able to continue to do in my research career. Okay, thank you.
Thank you.